Welcome to this workshop on schema therapy for eating disorders. In particular, this workshop will focus on working with eating disorders that might not respond to first line approaches, including people with complexity and chronicity, and also people who have a range of other disorders alongside their eating problems. My name's Susan Simpson. I'm a clinical psychologist and schema therapy trainer, and I'm based at the Regional Eating Disorders Unit in NHS Lothian near Edinburgh, and also run Schema Therapy Scotland, which provides training for schema therapy for eating disorders. So in this workshop, we'll be looking at a range of issues. We'll be first of all looking at treatment gaps. Where does schema therapy fit into the treatments for eating disorders? Why we would consider schema therapy and particular clients that it might be matched to or more helpful for. So we'll be looking at the rationale for using schema therapy for eating disorders, and also a little bit at the current evidence that we have for this approach. And I'll provide a case example, and we'll have at the end an imagery rescripting example of what we might use for somebody with an eating disorder. So to start off with, I'd just like to provide a bit of background to why we would be looking at schema therapy for eating disorders. As most people here will be aware, CBT is the treatment of choice for bulimic disorders, specifically bulimia nervosa. It reduces symptoms relatively quickly, and also somewhere between 30 and 60% of those with binge eating disorder tend to respond well to CBT. But in spite of these promising findings, there's a significant proportion of people with bulimic disorders who don't respond to CBT, with about 60% of those who have received CBT retaining their eating disorder diagnosis at 12 months post-treatment. And although CBTE has improved outcomes, there still remain around about 40 to 50% of sufferers who don't respond to treatment. In one recent study at 2 years post-CBTE, 44% of those with bulimia nervosa were found to be abstinent, and over half remained symptomatic. So that was a Poulsen et al. 2014. Anorexia nervosa in particular remains quite difficult to treat, and CBTE outcome trials show high dropout rates and limited effectiveness. So for bulimia nervosa, we're looking at around about 25% dropout, and about 50% of those who don't drop out recover. And attrition rates are approximately 50% for anorexia nervosa for CBTE, and approximately a third of those with bulimia nervosa and bulimic disorders, what used to be referred to as EDNOS, tend to drop out of treatment. So I guess what we're looking at here is who doesn't do well with our first line treatments. We know that some people do well, and I guess one of the things that we need to be working towards is figuring out what are the characteristics of those people who don't necessarily respond to those first line treatments. Who are the people who drop out, and who are the people who don't necessarily have good outcomes even when they do stick with the treatment. So I guess when we're looking at schema therapy for eating disorders, we're really looking at, I guess, some of these background factors that tend to predict poor outcomes. And some of the factors that appear to influence outcome include the egosyntonic nature of eating disorders, especially anorexia nervosa, high levels of both axis 1 and axis 2, as it used to be called, comorbidity, so high levels of personality disorder, so approximately up to 69% meet criteria for a personality disorder, or maybe have quite strong personality traits that maybe interfere with treatment outcomes. Up to 93% have a concurrent axis 1 disorder, so that would obviously be mood disorders, anxiety disorders, and a range of other disorders. So we're looking at, I guess, rigid characterological traits, high levels of negative core beliefs, prevalence of personality disorder, all as factors which have been linked to poor outcomes in this population. In particular, obsessive compulsive personality disorder and avoidant personality disorder are very common in anorexia restrictive subtype and binge eating disorder. And borderline personality disorder is very common in bulimia nervosa and anorexia nervosa binge purge subtype. The research suggests that personality disorders persist beyond, even when the eating disorder is successfully treated, the personality disorder generally persists. And this is particularly the case for avoidant personality disorder. We also know that, I guess, levels of trauma and invalidation tend to be high in this population. So this is another factor that's often neglected in the treatments that we offer for people with eating disorders. Patients with eating disorders frequently report a history of childhood trauma, and several studies have shown a strong association between childhood traumatic experiences and the severity of eating disorder symptoms. In particular, a history of childhood abuse and sexual abuse and emotional abuse have been found to be non-specific risk factors for the development of eating disorders. Emotional abuse and invalidation are the strongest predictors of eating disorder severity, so even stronger than that of childhood sexual abuse and physical abuse. So we're really, I guess that's something that is really important just to keep in mind, is that any treatment that is going to, in order to improve effectiveness for people with a history of childhood invalidation or emotional abuse or neglect, we need to really be, I guess, addressing those factors. Emotional neglect is reported by over a third of patients with eating disorders. And generally people with bulimia nervosa report more moderate to severe trauma than those with anorexia nervosa. And the other thing is that psychiatric comorbidities are higher in eating disorder patients with a history of childhood trauma. So we're looking at, I guess, more complex picture for people who've experienced childhood trauma, more comorbidities, more severity of eating disorder. And there's a significant amount of research out there that is showing this at the moment. So how does comorbidity of personality disorders and eating disorders affect outcomes? Well, comorbidity has been found to play a significant role in predicting treatment engagement and effectiveness. As I say, anorexia nervosa with comorbid personality disorder is associated with higher treatment dropout and poorer treatment outcomes. Cluster C personality disorders in general have been found to affect clinical outcomes for binge eating disorder as well. And in bulimia nervosa, some studies suggest there's less effect of personality disorder on outcome. Other studies showed the opposite. So at the moment we don't have enough information to really make any strong conclusions one way or the other. The other thing to bear in mind is personality traits. There's quite a lot of research to show personality traits have a significant relationship with eating disorder severity, and a range of personality traits have been found to be highly correlated with both eating disorder severity and negative treatment outcomes, including impulsivity, compulsivity, avoidance motivation, and affective instability. And one thing that I guess most people working in eating disorders will be aware of is that perfectionism is very, very high across the board, across all eating disorder diagnostic groups. And we also know that the findings on CBTE, although there is a specific component that looks at perfectionism and addresses perfectionism, the findings are very mixed in terms of whether or not that is effective. So we really need to be looking at finding ways of addressing these personality traits, especially as we know that they're linked to severity and outcomes for this client group. So preliminary research suggests that schema therapy is effective in a range of areas that have high comorbidity with eating disorders. And this is a factor which suggests that it may be quite an important treatment to consider for this population, especially as schema therapy treats all of the comorbidities at the same time. So it doesn't treat the eating disorder and then the depression and then the anxiety and then the perfectionism and the borderline personality disorder or whatever is going on. We're treating it all as one integrated problem that we want to address. So we have I guess, more complex formulation that can account for all of these different components of the person's difficulties. So schema therapy has been found to be effective with borderline personality disorder. Both group and individual trials have shown that it is effective and it is a recommended treatment for borderline personality disorder. It's also been found to be effective in randomized controlled trials for cluster C personality disorders. And preliminary studies also indicate that it may be effective for chronic depression, substance abuse, agoraphobia, complex PTSD. In particular, a recent study that was published last year, in 2020, which compared the schema therapy imagery rescripting with EMDR for complex PTSD, and found both treatments effective. So as I say, it's really important, I think, when we're looking at an eating disorder as part of a bigger picture, including, I guess, these other comorbidities, to look at the evidence base for the comorbidities, to look at what works for this client group, especially if we're looking at matching treatments to clients' needs. And these are trials that have found effectiveness for borderline, as I say, and cluster C personality disorders. We also have preliminary evidence of schema therapy for eating disorders. A randomized controlled trial by Ginny McIntosh in New Zealand found that schema therapy was equivalent to CBT for people with bulimic disorders. So that was the first randomized controlled trial, which is very exciting. And for these clients, they were offered weekly therapy sessions for 6 months and then monthly for 6 months. So that was their treatment, and as I say, equivalent outcomes. The other studies listed here are case series and case studies, and there are more findings coming out in due course. In this slide, I've just put up a couple of case studies. So these case studies are also, I guess, a qualitative description of the way schema therapy works with eating disorders. So what is schema therapy? It's an integrative treatment. And it's a unifying theory and treatment that draws on a range of other therapies, and that includes developmental and attachment theory, It integrates aspects of CBT, psychodynamic, object relations, and Gestalt, and a range of other experiential models. So it's a very integrative approach. It's unashamedly, brings together, the best of a lot of other approaches. And it was really developed for people with high complexity, high comorbidity, people who've become stuck and are not making progress with first-line treatments, and those whose difficulties may stem from some childhood patterns, including childhood trauma, abuse, and neglect, but not necessarily big T trauma. It might be more attachment issues, systemic family issues. And Schema Therapy really targets those entrenched belief systems and high levels of avoidance characteristic of people with rigid personality traits and complex eating disorders. Those traits that often interfere with treatments in a conventional CBT setting. So it's really very effective for people whose difficulties are egocentric, whose difficulties are tied up with their identity. This is the way I've always been. I can't imagine who I would be without my eating disorder, that kind of thing. Also very effective for people when CBT becomes stuck. We know that people who, if they're going to respond to CBT, generally will have started to make behavioural changes within those first 6 sessions. That's what the research suggests. So after that, we might be looking at other approaches that might benefit this person if they're stuck, or if they've been through the CBT treatment and not responded. It's really about offering people choices and matching treatments to people's needs, patients' needs. So we're really looking at in Schema Therapy on an expansion of what we might consider in a traditional CBT setting. There's more emphasis on the therapy relationship. Is a slightly longer term treatment focus. Our group Schema Therapy trial for eating disorders was 30 sessions of 30 group sessions plus 5 individual sessions. We've also had one since then, which has been 25 group sessions and 5 individual. So the length of the treatment is being shortened significantly. But there will always be, some people with more significant difficulties who will need more longer term treatment, especially people with trauma and attachment issues. There's more emphasis on working with emotions and mood states. So we'll work through imagery rescripting, role playing, historical role play exercises, which is a form of psychodrama, and chair work. So that's really working at a deeper level than just, people's cognitions. We're going below the surface to where the emotional pain is and where the healing work needs to take place. So we're working on, the way the person feels about themselves at that core level, at an emotional level, not just at a cognitive level. We do that through, trying to understand how these patterns emerged, through looking at childhood origins and developmental processes, not in a blaming way, but really in an informative way, in a curious kind of way. I wonder how this developed. I wonder what happened to you for you to need this way of coping. And more emphasis on lifelong coping styles. So we're looking at patterns of coping, patterns of avoidance, patterns of overcompensation, rather than just looking at specific symptoms. So rather than looking at, for example, binging or self-harm or any of these strategies as individual strategies, we'll be looking at them in the context of a wider range of avoidant coping, for example. And there's more emphasis in Schema Therapy on entrenched core themes. So we're looking at schemas and modes rather than symptoms on their own. We're looking at patterns and how they've developed in the person's life. So we have these two models, I guess, in schema therapy. The original model was the schema therapy model, or schema focused CBT. It was referred to by some people. This really focuses on the 18 maladaptive schemas or beliefs, and it really works with, I guess, each individual schema or each belief. It's still very useful, but we would tend to use that original model with more high functioning patients now. But this model underlies, I guess, the schema mode model, which is what we will tend to use most of the time, and especially most of the time with our eating disorder clients. It's very well suited to the eating disorder population, especially for those with more complex difficulties. And it's really about different parts of self. So this is a different side of me. This is a different part of me. So it's not just, it's about looking at the individual person as made up of different parts, that we all have these different sides or different parts that come to the surface or are active in different times in our lives when different things trigger us. And so we're trying to identify and get to know these different sides of self. And we know as well that with people with eating disorders, they often describe eating behaviors as occurring, for example, in a trance-like state. I was binging and I was just kind of felt like I was in a trance state. I wasn't really able to access what I was feeling at that time. Or I was on a high, I felt empty and I was on a high. But there's this, I guess, detachment or dissociative aspect of these sides of self, these different modes. Or patients will sometimes describe, I want to get better. I can't understand why I keep relapsing. I can't understand there's this other side of me that keeps, this anorexic side that keeps pushing me down and sabotaging my progress. And there's this, I guess, what they perceive to be this bad side of themselves that they're fighting. But we want to bring these parts to the surface, get to know these different parts, find out what's driving that anorexic part, or the bulimia nervosa, or whatever eating disorder we're focusing on. We want to really get to know these different sides that are driving the eating problems and the other problems, the other comorbidities. So we're really looking at, I guess, bringing together and understanding the person's difficulties in terms of, I guess, an integration of temperament and environment. So that very often people with eating disorders describe, I guess, a very sensitive temperament. They're very empathic, often picking up on what other people feel, often before other people are picking up on it themselves. They get, they're very, very caring, as a general rule, and quite sensitive, often anxious temperament, and that's there's been quite a lot of research, of course, that's looked at that anxiety as a temperament factor in this population, and potentially a low tolerance for uncertainty in this population as well, which goes with the anxiety. We're also looking at, I guess, general environment factors like culture, body objectification, which is obviously very common in the media, and in our culture in general. We're also looking at parenting style, family beliefs around food, weight and shape, and availability of emotional support of the family and the wider system. Emotional support, not just in a general sense, but in a kind of a emotionally present sense, being able to be emotionally present. And this is, I think, a very key factor with when it comes to the needs of someone with a very sensitive temperament, is they'll be able to tell if you're actually there, if you're not just physically present, but emotionally present and available. Peer pressures, bullying, of course, is very common in this population in childhood, and messages from teachers, wider family, as well as experiences of abuse, trauma, invalidation, and neglect. So all of these factors, I guess, bounce off the temperament of the person, and this, I guess, then leads to either emotional needs being met or not met. and then schemas or modes, maladaptive modes, develop when the person's emotional needs are not met. So if we think about our emotional needs as our our vitamins, our emotional vitamins that we have as children, if we don't get those emotional vitamins met, then just as if we don't end up with certain nutritional vitamins being met, then we're going to develop difficulties in certain areas and schemas in certain areas. So these are the emotional vitamins, if you like, the 5 core emotional needs, or clusters of emotional needs. So if we think about these different needs in relation to eating disorders, and think about what it might look like if these needs were not met. So somebody who didn't get their needs for secure attachment to others met, this might include people who were physically, sexually, emotionally abused, might have experienced a lot of criticism or an absence of emotional attunement. There wasn't somebody emotionally available, especially if the parent's very stressed, or if the parent's very anxious and the parent didn't get their needs met, or if the parent's depressed. It's very difficult to provide these things for a child or a baby if you have postnatal depression, or if you have anxiety issues, or if you're very stressed and anxious with your own problems. So we're not looking at blame here, but we're just looking at understanding, really. How did these patterns develop? And conditional acceptance. If the child is accepted on the condition that they meet the parents' needs in some ways, or parents' expectations in some ways. And often this is very subtle, and the parents often aren't even aware, of course, that they're doing it. We can all think of instances as parents when we might have not met our child's needs in an attuned way. And I guess in this instance, we're talking about in a repetitive ways. We're talking about repisodes where this has happened over and over and over again, and the person's not got their needs met over and over again over a long period of time. There's no such thing as perfect parenting, and it's really here about looking at where the gaps are. That actually most parents do a great job, but we all have gaps, and this is about figuring out where the gaps are. And so in this person, if in this case, in terms of secure attachment, if it's conditional acceptance or love, it might be based on achievements. It might be based on being the good child. It might be based on compliance, that kind of thing. So the child starts to tie their self-worth up with pleasing others, or performance, or meeting the parents' needs in a particular way. The second category, autonomy, competence, sense of identity. The needs might not be met if there's overprotective parenting, overly intrusive parenting, if the parent does too much for the child, if there's a lack of praise and encouragement for the child to go out and be autonomous and self-reliant at the right stage. So we're not talking at early on in life. We're talking about it, for example, when the child's 2 or 3 and they're going out into the world and starting to explore and wanting to come back, that they're encouraged to do that they have the safety to do that, to develop those early stages of autonomy without being pushed to do too much too early. So it would, of course, for the that can develop too early as well, where the child's kind of potty trained when they're 6 months old and so forth. So those dependency needs aren't met enough in those instances. So we're talking about, I guess, meeting those developmental stages when we think about developmental psychology, really looking at were those needs met in those different stages. In some instances, of course, we know that the parent needs the child to need them or to be dependent on them, or the child's discouraged from developing their own identity, or the parent feels threatened by the child expressing their own opinions and views and plans for independence, or feels threatened by the child going out and meeting their own friends because of their own insecurities and feelings of abandonment, the parent's feelings of abandonment. Freedom to express needs and emotions. So the child's discouraged from expressing their feelings or for asking for what they need if these needs are not met. So the parent might say, something like, can't you see how hard it is for me? Or, yes, well, I know that it's been difficult for you, but we've all had a hard day. So there's that kind of, I guess, invalidation. Or maybe guilt-inducing messages when the child expresses what they feel. After all I've done for you, I can't believe you would do this to me. You're just seeking attention with your eating disorder. So there's this kind of guilt-inducing message that's associated with the child expressing their feelings, their views. Or it might be that the parent doesn't express their feelings, that they model emotional inhibition. Or if the parent doesn't quite know how to attune to the child when they do express their needs and their opinions. In some cases, the parent's not done or said anything. In some instances, it's that the child has picked up on the parent's anxiety or stress, and they're trying to take care of the parent by holding back on expressing their own feelings because they fear that it will add to the parent's stress or anxiety, even though no one's ever really had the conversation. Spontaneity and play. So for families which are ultra kind of serious, where there's a real emphasis on schooling, on achievement, on performance, on structure, where they're going to the right school, etc., at the expense of fun and play. Or it might be that parents have their own difficulties regulating their own emotions, might be depressed or in pain, and the child's going to learn to tiptoe around. So there's a lack of laughter, silliness, free time, play, spontaneity in these families. And finally, realistic limits and self-control. So we're talking here about a lack of consistent discipline, the child being held accountable and having consequences if they don't do the things that are important for them to, I guess, see things through, do the things that are going to lead to good outcomes for them in their lives. Just not being not being helped to, I guess, follow through with rules and boundaries. The parent might be very punitive in some instances, but still unable to enforce consistent boundaries. It's kind of very haphazard parenting. Or it might just be more subtle, that the parent is kind of more like a sibling than a parent, not really encouraging the child to do their homework, get to school on time, eat 3 healthy meals, etc., and limit their kind of more unhealthy pursuits. So just keeping in mind those needs and whether or not those needs are met, that our formulation in Schema Therapy will be really, I guess, drilling down on what is the temperament, what were those childhood experiences, what were the needs that were met and weren't met, what are the sides of self or the schema modes that developed when needs were not met. So we have healthy schema modes that are developed when needs are met. A healthy adult, for example, a happy child. We also have modes that are there or take on an unhealthy function when needs are not met. And the way that we learn to cope when our needs are not met as human beings will influence, I guess, what those cope-specific modes are. So these are, I guess, clusters of schemas, clusters of beliefs, experiences, memories, bodily felt sense that may be adaptive or maladaptive, that are currently active. So these are the states that we all experience, moment to moment emotional states and coping responses that we all experience. And schema modes are triggered by life situations to which we're kind of overly sensitive, like our emotional buttons, if you like. So the modes are, I guess, divided into 4 main categories. We have the child modes, which is, I guess, our emotional modes, the parts of us that we all have, that we're born with, where we're vulnerable, where we might be angry or sad or anxious. But this is where the state in which we experience our basic emotions. When we're not getting our needs met, And this may be through inner critic messages. It might be through direct inner critic messages where we were criticized or put down or given guilt-inducing messages. Now, these inner critic messages might come from parents or grandparents or wider family or culture or media or peers or teachers or all of the above. So it can be a real range of sources, these inner critic messages, but they're really internalized messages. They're like an echo from the past that just plays over and over and over in the person's head. So if they were bullied in the playground at school and told they were fat and ugly, then that's the message that they hear over and over and over again, and it kind of snowballs into this inner critic side of themselves that just feels normal and familiar. It might have more of a punitive tone, it might have more of a kind of demanding or pushing tone, or it might be more guilt-inducing, where the person feels guilty all the time for getting their own needs met. So these, I guess, child modes are always there under the surface. The inner critic modes are often there attacking the child parts of ourselves or the vulnerable parts of ourselves. And the coping modes are parts of the self that have kind of developed to cope, to get through not getting our needs met as children. And when we think of our patients with eating disorders, often this is where the eating behaviors come in, where the person has learned to cope through using eating behaviors, through using self-salvation, and through, aiming for some kind of perfectionistic outcome in terms of how they would like to be, but also, coping either through a range of avoidant or overcompensatory coping mechanisms. The healthy adult is the healthy mode that we really want to develop, strengthen. Many of our clients have got stuck in the development of their healthy self and become very fused to a coping mode, and that has become their identity. So this kind of more over-controlling, perfectionistic part, they would see that as their healthy side. And so when they're trying to recover from their eating disorder, they're trying to recover from a side of themselves which isn't their true authentic self. And it's more of, the mode that's also driving their eating disorder. So they're trying to use the same thinking and the same coping mode to get out of the eating disorder as, what got them in that fix to start with. So we would be really looking at accessing and strengthening the healthy adult side in Schema Therapy. Now, the child modes, these are the parts we're really always trying to get to in Schema Therapy. So these are always usually backstage. So front stage, we might have the coping modes, which I'll talk a bit more about in a short while. So they're the parts of the client that they've learned to develop, to cope with the world, to cope with not getting their needs met. Whereas behind the scenes, backstage, is these child modes, which often they feel very ashamed about, and which their inner critic will attack and shame them for. So the shamed or deprived or vulnerable child feels rejected, hurt, shamed, unwanted, desperate for love, but scared that they'll be rejected or abandoned. The impulsive child feels like they can never get enough of what they need. So there might be impulsive binge eating. They might use other substances. They might use drugs or alcohol or self-harm as well, deliberate self-harm. They might also be rebelling against control, acting on impulses. And there's often an overlap between impulsive child and angry, rebellious child. The angry part is often underground for our clients. Very often with eating disorders, clients have become very ashamed of their anger, and so the angry part acts out through their eating disorder in a kind of semi-pre-conscious kind of way. So it's expressed through kind of passive-aggressive behavior and sometimes eating behaviors as a way of kind of, I'll show you, I'll keep restricting because I'm going to keep hold of that my own self, my own autonomy. So on the surface, I've got this smiling, happy coping mode that's going along and trying to do the right thing and be the good girl. Underneath, I've got this angry, rebellious part that's saying, I'm going to do my own thing and I'm not going to conform. But that part's often kind of pushed right to the backstage out of conscious awareness because of the shame that it elicits. And happy child part is the part also that we want to strengthen, just like healthy adult, where the body is seen as a positive part of themselves and the person uses their body appropriately for play, for to express their feelings, pleasurable activities. So the inner critic modes are one of the parts that we're trying to get rid of. It's the only part actually that we're trying to get rid of. So all the other parts are part of the client. We would see them as being an integral part that they're born with or developed as a way of coping. And we want to integrate all the modes as part of the treatment. Inner critic we want to get rid of because it's as much as we can, given that it's an echo and it's just playing over and over and has become internalized. But we want to sideline this mode because it's not a part that the client was born with. But it is a part that is driving the rest of the system, driving the coping modes, pushing the coping modes to keep coping in this way because of these unhealthy messages. Your needs are too much, you're undeserving, you're a monster, you're barely human, you're fat, disgusting, unlovable, etc. You've heard it all before. Or it might be more pushy, more demanding. Where's the extra 10%? Couldn't you have done a bit better? 90% for an exam. What happened to that 10%? What went wrong, kind of thing? Or more guilt-inducing. Can't you see how your illness is hurting all of us? This kind of thing. So these are the messages going through our clients' minds, and I guess really reinforcing this idea that there's something shameful about them, that they're too much, there's something wrong with them, and this, as I say, becomes reinforced over and over, and hardwired, if you like, over many years. In this diagram, this is a picture drawn by one of my clients who had a range of inner critic messages. She had very invalidating messages from her parents. Her parents were actually very, very nice people, but very invalidating. And she also had an uncle who sexually abused her. So for her, these little red devils, as she called them, this was the black figure is the inner critic sitting on her shoulder, sitting in her head, and then these little devils are like the inner critic messages attacking her, trying to pervade her and contaminate her, if you like, so that she kind of felt like she was always under attack from this inner critic. I've just flashed this diagram up just so you can see here that the parent, what's called here is the parent modes. They used to be called parent modes, but we now call them inner critic modes because there's acknowledgement that these messages come from all sorts of different places. But these punishing or demanding inner critic messages attack the vulnerable child part and make her or him feel anxious, sad, lonely, ashamed. So these coping modes in the middle here are what we would normally see. These are the parts that hold the eating disorder, where the eating disorder helps the person to avoid, to detach. It also helps them to express how they feel in a kind of passive way whilst going along in a compliant surrenderer way, kind of happy, smiling, going along with what others want on the surface. Or there might be more of an overcompensation mode where the person's very perfectionistic and trying to be the best, trying to be better than other people. So these are the three main ways of coping. Either avoidance, detachment, kind of where the person's kind of being very hyper-rational, intellectual, where they're very compliant, they go along with what everyone else wants, they're happy, they're kind of smiling and friendly. Or they're more overcompensatory, where they're trying to be as the best, trying to compensate for being that what they perceive to be, I guess, inadequate, shameful self by going to the opposite extreme and being the best. So whenever they, I guess, look at themselves in terms of, if we're talking about body image, this is, I guess, contaminated by these inner critic shame messages. That the way they see themselves becomes distorted by these schemas and modes that then, I guess, influence the way the person feels in their bodies, because, of course, these memories and patterns are held in the body. So we very much need to work with schemas and modes from a body perspective, but also in terms of the way they even see themselves in the mirror, obviously. So the reason we're really focusing on these developmental and childhood issues is because we want to help clients, we want to de-shame these experiences. Many of our clients come to us talking about, I'm the problem here. I've got this eating disorder. I don't understand what's wrong with me, why I can't pull myself out of this. They feel intense guilt and shame around the eating disorder, very commonly, and this is about starting to externalize, starting to look at, well, hang on, let's look at how this pattern developed. What happened to you for these problems to have developed, or for you to learn to think about yourself in this kind of hypercritical way? But we're also talking about how, I guess, this vulnerable part is a part that we all have, that developmentally this is an early state that we're all born vulnerable, and the coping modes and coping states develop as a way of the baby, the child, dealing with not getting their needs met. So we're, I guess, using that developmental approach to really develop a sense of understanding, to help the person see what the real problem is. Because often, of course, the eating disorder is often a smokescreen for all sorts of other issues going on underneath. And it's very easy for us to get caught up in the smokescreen and completely neglect all the issues that are underneath. Now, that insight is not enough on its own, of course, to address the eating disorder, but it makes it much easier, because if the person can start to see that, oh, so maybe it's not that there's just something odd about me and that my problem's kind of dropped out of the sky, that I've got this illness and it's kind of that it's happened to me, but rather they start to acknowledge that maybe this is a pattern that's developed as a response to things not being the way that I needed them to be at the time. And this also it's a painful realization quite often, that things weren't as wonderful as they perceived. But we're not bringing these issues up to blame. As I say, it's more so that they can start to process what happened and start to recognize what those needs are, so that they can get them met in healthy ways. Because otherwise, if they recover from their eating disorder but they're still not getting those needs met, they're much more likely to relapse or to develop some kind of symptom substitution and go off and start drinking or use other, I guess, addictive behaviors as a way of coping. So, as I say, we're really looking at, I guess, linking up the modes, these different sides of self, giving them a name. Here I've just given them very boring schema names, but with our clients, we would try and find out the characters of these different sides or states of self, give them a name that fits with that. So the over-controller mode might be the business mode, or it might be the bossy mode. This is the mode where the person's trying to get on top of their vulnerability. I'm too much. I've learned that somewhere along the line in my life, I learned I'm too much. I'm too needy. I'm a burden on other people. So I'm going to get on top of that. I'm going to get rid of my vulnerability, eliminate it through my eating behaviors, through my restriction. So there's this sense of emptiness, brings this real sense of invincibility at real high in this mode. So not only am I not, do I not have any needs, but actually I'm superhuman. I don't have needs that other people have, and that makes me special. So it's a kind of a way of trying to be special or on top, or to kind of be completely invincible, powerful. So they go from being the powerless child to the powerful over controller mode. So this is a very addictive mode, which often drives anorexic behaviors, but also the restrictive aspects of bulimic behaviors. Also OCD behaviors and other kind of compulsive behaviors can come into this mode. The detached protector is more of an avoidant mode. It might be more of through self-soothing, through binging, vomiting, self-harm, alcohol as a way of detaching and escaping emotions. So if something is triggering, somebody doesn't call when they say they're going to call, or the person feels abandoned in some way, in this mode they just avoid, they just shut down and just go and binge, and they don't have to think about what they're feeling. Compliant surrenderer is where the person's, I guess, trying to go along, trying to avoid conflict, abandonment, rejection through doing the right thing, being the good girl or boy, being compliant, at least on the surface. But behind the scenes, backstage, we have inner critic attacking that child mode, that vulnerable part of the person. So underneath, there's still this sense of worthlessness. There's still this sense of emotional pain, loneliness, sadness. So the person tries to stay front stage as much as they can in these coping modes, so they don't have to feel and be in touch with the shame, the pain, the emotion, the anger that they're often very frightened of, and the impulsivity that they're often frightened of. So in this one, I was just going to, I guess, give a flavor of some of the different modes. So, for example, detached protector mode might come into session. The avoidant mode might come into session. Oh yeah, I'm fine. Everything's fine. Yeah, no, I'm working on my eating disorder. It's all good. No, I think I did a good job. So it's all just very flat. They might say, I'm fine, or they might say, I don't know. Everything you ask them, it might be, I don't know. They're kind of detached. I don't really want to go there. I don't really want to think about that. Or they might give you lots of detail. They might tell you about how they're feeling, but in a really detached way. So on the one hand, they're talking about feelings, which is kind of a bit of a decoy because you're thinking, oh, good, they're in touch with their feelings, but they're telling you about it with a smile, or they're telling you about it in a way that's not connected, where you don't really feel it. If someone's in overcompensator, like an over-controller mode, they might be saying things like, I've made a list, I'm really working hard on things, I've been studying a lot, and I've been really working very, very hard on my eating disorder, but today I just want to address everything on my list. So they're kind of very business-like. They've got their lists, they want to be efficient and productive and get through things, and I just need some strategies to help me deal with this eating disorder, and then I'll be all right. So they don't really want to go underneath to where the feelings are. They just want to kind of you to give them some often quite, I guess, unrealistically magical strategies that are going to help them sort out their eating disorder. And often you as a therapist will feel pressured and feel like, well, I've got to come up with some solutions here because I'm not giving them enough. I'm not helping them enough. So the pressure, you will feel the pressure when they're in this mode. Whereas when the person's in a compliant surrenderer mode, they'll be more, how are you doing? What's your week been like? I'm so, I really love our sessions. They're so good, and I'd love to do the homework and chair work. Absolutely love chair work. Now, I think when you're hearing those things, often it's because the client's trying to please you. So it's a coping mode that's developed as a way of trying to, I guess, keep you connected and to avoid rejection or abandonment. Angry child we rarely see in eating disorders. It might be that we see it in more of a passive aggressive way, where the person doesn't turn up to sessions, they're avoiding you, you feel that you've done something wrong but you don't know what it is, more of an angry protector. But if the angry child does come to sessions, it will be more of a kind of like a child acting out kind of thing, slamming the door, shouting, that kind of thing. So as I say, we would rarely see that in eating disorders. And more of a vulnerable child mode where we're trying to get to do the healing work is where the person is in touch with their emotions, where they're in touch with the sadness or the loneliness or the loss of what they've been through. Okay, so I'm just going to give a case example just to kind of give you a sense of how these modes fit together. This client, Karen, presented with anorexia nervosa. She was also compulsively over-exercising. There was a lot of other rituals, including hand washing, checking, counting. She had a history of chronic dysthymia, very low mood since early childhood, history of cutting herself, and very clearly met criteria for avoidant personality disorder. So very avoidant of other people, of kind of connection. She had avoided, I guess, most of the kind of social or work-related situations that most people her age would be involved in, and would spend most of her time on her own. She came from a background where she was very shy as a child, very anxious. And in her background, her mum was also very, very anxious and depressed. I found it very difficult to be emotionally present for her. Dad was very critical and controlling. And there was a lack of, I guess, closeness in the family, that nobody really was able to talk about their emotions. There was no overt affection expressed. And she felt like everyone was a little island, really. No one was connected to anyone else. Her parents were very preoccupied with their own conflicts, their own problems, and they separated when she was 9. And mum worked very long hours. Mum was away a lot. She worked often when, was gone by the time Karen woke up, and still not back by the time she went to bed. And mum had an extramarital affair, which put extra pressure on the parents' relationship. And the parents ended up separating for a period of time and then getting back together. Dad was very resentful, angry. He worked from home, very kind of shouty man. He would, when Karen would go to him and show him things or ask him a question, he'd kind of do a lot of, what do you want now? Kind of response because of his own distress, his own anxiety, his own problems, and so she kind of got that consistent message that, look, your needs are too much, and you're too needy, you're a burden, I've already got enough on my plate, kind of thing. So Dad was kind of quite distant, quite rigid, very rigid ideas, very shouty, and Mum disapproving. And on top of that, she was bullied and ostracized at school. So real unmet needs around attachment, attunement, emotional availability and warmth, a lack of empathy, a lack of praise, and a lack of help with dealing with her own anxious and fearful temperament. How to navigate that. So she developed, I guess, a range of beliefs around her schemas, linked to her schemas. I'm weird, I'm different from others, I'm disgusting, unlovable, worthless, evil. I must submit to the control of others will leave me. Now, no one ever said to her, you're disgusting, you're unlovable, you're worthless, you're evil. It's more of a kind of snowball effect of, I guess, all of these experiences and just not getting her needs met, that sense of worthlessness that came from not getting her needs met. And I guess this developed as a kind of a secondary snowball effect of that. So for her, this is her mode map. You can see the inner critic on the left here, which is kind of you're weak, you're pathetic, you're wrong, your needs are a burden, you're undeserving, etc. And little Karen, who is being attacked, is feeling anxious and guilty and like she's the problem, feeling rejected, feeling trapped, feeling powerless. and the angry child feeling angry about that, but unable to express that anger because there's already too much anger in the family. There's already too much disconnection in the family. So if she was to express her anger, that would have added more stress to the mix. So for her, her anger was internalized towards her own body. So her self-harm, her eating disorder became her way of directing that anger inwards to try and preserve her attachment to her parents. The modes that she, I guess, coped in, her coping modes, were her kind of perfectionistic over controller, restricting her eating, being very perfectionistic, being productive, being lots of rituals and rules around OCD, and exercise, self-harm, and also this kind of compliance surrenderer, kind of being passive, being the good girl, being what everyone else expected and wanted her to be, but never feeling like she could match up, really, just kind of constantly striving to reach this unreachable goal, because at her core she still had this inner critic, vulnerable child kind of dynamic going on, where she was still constantly feeling that she was the problem. So the treatment, so having, I guess, come to that mode map, we would then be looking at how to start to address that, I guess, those very core negative self-critical beliefs. And we do that in schema therapy through these experiential techniques, focusing on, I guess, changing deeper level experience and felt sense of who I am as a person. So we would do that through chair work and imagery rescripting. We would also use interpersonal work, where we're trying to get in contact with that vulnerable part, those child modes, to get past the coping modes, to get that connection with the vulnerable parts of the client. We would do some cognitive work, challenging those schemas, those core beliefs, and we would also do quite a lot of behavioral change work, where we're trying to shift those behaviors. So, for example, if binge eating is the person's way of coping, we would be looking at, I guess, changing those behaviors and helping the person get those needs met in healthier ways. So if binge eating meets the need for comfort, for soothing, for regulating their emotions, then we would help them find more, to have the experience of getting those needs met in healthy ways interrelationally. So not just through strategies, but through connecting, through co-regulation, through learning to, I guess, parent themselves from the healthy part. Now, at the end, I'm going to play an imagery rescripting exercise, just to give you an example of what that would look like. So I'll come back to that to show you right at the end. But imagery rescripting is most definitely one of the techniques that I've used a lot with Karen, to try and shift that belief that she's bad, she's the problem, at a very core level. So we're really trying to help our clients get their needs met in an adaptive way. So no longer trying to let go of getting their needs met through their eating disorder, through their OCD, through their other coping mechanisms and other comorbidities, and starting to get their needs met in healthier ways through cultivating this inner healthy adult self. So we're doing that through empathically confronting, trying to get past the modes in front center stage. So those coping modes like detached self-soother, detached protector, over controller. So we need to get past them. So we wouldn't, if a client comes into session in a very detached way, we're going to be trying to get through and past that to the vulnerable part underneath, so that we can nurture, validate, and do the healing work. We would also be doing chair work and imagery work, where we're confronting and setting limits on those old messages from the past, the inner critic messages, and strengthening and empowering their healthy adult and happy child modes through imagery, through chair work, through the work that we do in historical role play as well. So we're looking at, I guess, using a range of techniques to start to challenge these beliefs that are held at a very deep level. So, in summary, this is a very integrative approach. It has an active focus on accessing these deeper level thoughts and feelings. So we're trying to get past those pseudo mentalizing coping modes that the client comes to session in. It's more structured, utilizing a broad range of strategies, but we're not in schema therapy. It's not structured in the sense that it is in CBT. So it's not, I guess, we don't set an agenda per se. We might roughly set an agenda, but it's more of it very much depends on what state the client is in, what coping mode they're in, as to how we will how the session will go and how we'll do the work. So we always have a broad goal of getting to that vulnerability, but it depends on what mode the client is in as to how we get there and what we do once we're there. So as I say, I guess the other key elements of schema therapy, just to summarize it, this developmental model is really attachment focused. It's about getting needs met in healthy ways, about our clients being able to own their needs and being able to say in words, I need this, and not feel ashamed of those needs, even though the messages they've had in the past have I guess, been shaming. It's the emphasis is on working with emotions rather than rationalizing, challenging beliefs at a cognitive level, solely at a cognitive level. So we're going beyond intellectual change. We're going to a kind of a really emotional, at an emotional level, working at an emotional level. Reparenting is really about coaching the client's healthy adult self to take care of themselves, to look after themselves, to reparent themselves. So we might start that work where we're reparenting their vulnerable part, so that we can coach their healthy adult to do that. So it's really about helping them to get there, to be aware of their different sides and to actually have a healthy side that is running their whole system, that is coordinating all their modes, and rather than gratifying their coping modes. And so we're trying to, I guess, do that healing work from the inside out. So it's not just strategy based or giving techniques. It's really helping the person to, I guess, go through those developmental stages that they've missed, to actually go through that, almost like simulating a development from the point that they got stuck in their past, and allowing them to go through those developmental stages in therapy. So as I said, we can't solve our problems with the same thinking we used when we created them. As Albert Einstein said, we don't want, I guess, if we're purely using cognitive approaches, very often we can get stuck in this situation where, and especially for clients who don't do well, where they're trying to recover from a coping mode. They're trying to recover from a mode that is all about thinking, but is not about feeling. And we need to be more integrative in the way that we work with clients so that they can feel better about themselves, feel and be able to be more embodied in order to move forward. So just some resources at the end of the slides, and you'll have your own copies of the slides. So this is a book, Schema Therapy for Eating Disorders, and we also run courses on schema therapy for eating disorders. More details can be found on the website. So I'm just going to go back to the slide on fighting the punitive antagonist, and I'll attach that in a separate file so that you can watch it if you have time. So thank you very much for listening to this workshop. It's been a great opportunity to meet with you, and I'll be at the conference for the last hour of each day of the conference if anyone has any questions, and so I'll look forward to seeing you then. Okay.